Professor Lichtenstein needs no introduction. He is an incredible researcher, educator, faculty person, writer. He's created the Blue Protocol, Falls Protocol, SESAME Protocol, multiple books. And we're also going to learn more about CEURF, C-E-U-R-F. He's going to tell us more about the background of lung ultrasound here in Paris. I've been loving the history. And just anything else that he thinks is important for us that we have yet to hear or read about. So I've been loving all of the Paris history, and I've read some of the content of your books, your papers, etc. With history in mind, I was wondering if you would tell us about your background and how you came to love and do so much in lung and critical ultrasound. I know it's a big question.
It's a nice program. So first of all, I am so glad to meet you and to see you in person, that is face-to-face.
Yes,
and
it's lovely.
Because we eat a lot of webinars currently, and it's a bit claustrophobogenic, if I can say the word, and to see people really like this, it's a great honor, of course, first of all, but it's also a very relaxing moment. So your question is very elegantly set, that is how did this love for ultrasound come to me? I love it because it is a love story. That's the good word. When you are a student, you learn medicine, but you do a lot of work that other people don't want to do. And one morning, it was a Saturday morning, in a hospital, Laennec. So Renee Laennec, I make one bracket, was the inventor of the stethoscope, and not only the stethoscope, but few people know that, but a whole different way of thinking at the bedside. And it was now 99% because of the stethoscope. That is a bit funny. So I close the bracket. I was at Hospital Laennec, and it was a Saturday morning, it was a blue sky, and the chief said to me, Daniel, this lady needs to have an ultrasound of the belly. You take her to the radiology department. And I said, yes, because when you are a student,
you do it.
You do it. So I was with her help, and altogether we were in this radiology department. And there was the radiologist who saw the paper, saw the lady, who sat down on the bed, and taking the ultrasound machine, began the examination. And I saw the screen, and I heard the guy saying, okay, so this is the gallbladder. You can see the gallbladder with that machine. Okay, so there is some fluid, some peritoneal free fluid around the gallbladder, very few. I said, he can see fluid, even very few around the gallbladder. For me, it was surrealistic.
Yeah,
and
yes, me too.
He made the Murphy's maneuver, etc., which was painless, by the way. I don't remember, to be frank, what happened with the lady. She was not scheduled for immediate surgery. That's all what I know. And what I saw was that machine to see inside the body. I said, that is great, and I think this is this day that I falling in love is maybe not the good word, but I was completely fascinated. I said, what a potential. And then I wanted, when I was a resident, I succeeded a very difficult, what's the word, le concours, when a few are called among many, it's a concourse. Well, let's forget.
Sure. But so competitive.
Very competitive,
okay.
Yes, I had it. And I wanted to make something something that moves. Acute medicine, emergencies, intensive care. And I had the opportunity to work in the intensive care unit. And I was very young. I made my first night shifts. And retrospectively, I said to myself, but how can somebody make his first night shift in this profession? But when it was time, I was just terribly excited and terribly scared.
Of course, yes.
Both, as any normal doctor. We all remember these things.
Yeah.
And one day, or one night, in 1985, I was with a difficult patient. The X-ray was white. One side of the chest was white, and they said to me it's full pneumonia, and the patient was not well. And I said, we must do something. I forget to say that before doing this, I used my residency that makes 8 semesters, and I devoted one to go in the radiology department to learn the very, very basis of ultrasound.
Okay.
The very basis, but how to see a liver, how to detect liver tumors, etc. And thanks to that, I said to myself, with that patient, I need to know more. And I went to the radiology department. It was midnight. There was nobody, of course.
Of course.
And I saw a big machine. I unplugged it. I went in the ICU, plugged in it, and I saw that the white lung was, because there was a consolidation, of course, but there was also a lot of fluids, and too much fluids. And I said to myself, maybe it prevents the venous blood to come back to the heart. That's why maybe the patient is so unstable. And I did the procedure.
Yes.
I had the feeling that the patient was better after withdrawal of 2 liters of dirty fluids, by the way. And once the parameters that for me were important, that is blood pressure, heart rate, capillary filling time, that's what you call.
Yeah.
I said, okay, I have time to bring the machine back to the radiology department, and there was nobody.
I was curious if you would get in trouble for it.
It was forbidden for various reasons. First, the ultrasound did not belong to us, but to the radiology department first. Second, who am I? I am not radiologist or cardiologist, so I did not learn this tool officially. And so anybody could say to me, what have you done? You made with that patient some disaster, and I don't want to hear about it any longer. End of the story. And I said, you must find a place where you have the ultrasound. I was looking in the planet, nobody was doing that. And a good friend of mine, Gilles Roudy, said to me, but there is an ultrasound machine in the intensive care unit. It's my good friend, François Jardin. I said, okay. I went, 1989, I knocked at the door of this intensive care unit, which was at this time already a prestigious ICU and famous for the few experts that understood this, for the use of echocardiography. In this ICU, you find a world expert of echocardiography and somebody who makes all the rest, that is, who develops the whole body ultrasound. And I open a big bracket, big one, whole body. That is, the lung was part of the bundle. I discovered that the lung was able to speak, to say something. It was unexpected. It came little by little, step by step. And I realized that the whole body was a cake, big like this.
Big cake.
And the lung was, so to speak, the cherry on the cake. And I have the feeling today, in 2023, that many the doctors who know me think that I am a big expert in the lung ultrasound, whereas my work was to develop the cake.
Okay.
But unfortunately, when you want to change one comma in medicine, you have to spend 10 years. So this cake was too big for me, and what the community has kept in mind is, that's the specialist of the lungs. I smile of it, I accept it, because it is true that the lung is the most vital organ. And I will immediately add, ex aequo with the heart. The two make 100%. I would say the lung makes 49 and the heart 51 if I want to be polite.
Okay.
Or I can say the lung is 51 and the heart 49 if I want to be logical. The heart is a driver. He has to transport this in some place, and the lung extracts the vital oxygen. So I can say that it's a bit funny that the lung is a little bit more than the heart, but you are free to cut it when you will make the final cut.
No, I appreciate the give and take. So people will hear of that whatever they want. I probably will go 51% lung as well. And I think coming from the American standpoint, I think the reason why your name is so synonymous, or when we hear it, we think of lung ultrasound is the blue protocol is everyone and their brother. Like everyone has heard of the blue protocol. So I think that's the thing that sticks in people's minds. But I know you have the other again, so the Falls, the SESAME. And then I wanted to, if you don't mind, so we heard the history kind of coming up to where we are, and it makes sense that you're able to do so much training and teaching and education here. You have these long relationships and you know people. So I wanted to see if you would tell us about CEURF, so CEURF, and I would love to hear about what you think is unique and why and how you've constructed it, because it sounds pretty fabulous.
So this is how the CEURF was born, and it was very.
And what makes it
clinical,
special?
Because it was teaching ultrasound to doctors who are not radiologists or cardiologists. That was unusual first.
Yes.
It was done in the intensive care unit with not healthy models but patients.
That's the secret sauce right there.
With real disease.
Yeah.
It was, in this aspect, it was rather ethical, because initially, in 1989, where it began, life was not the life of today, and to have a CAT scan, you see a total densitometry in a patient, today you have to say that, so make a CAT scan to this patient. It's easy to say, it's more difficult to implement, and sometimes dangerous and sometimes deadly.
Sure.
For those who have the money to have a CAT scan in their countries, they said, oh, but there is a jugular internal thrombosis in this patient. Look, it is floating. You see what I mean, of course. That is moving, something that you cannot see on the venography that was done at this time. And so I interrupted the lesson and I spoke to my colleagues to say, this lady in the room 10 has a floating thrombosis here. And I let my colleagues deal with that problem. So these things were rather not usual. And the less usual thing was the whole body approach of the patient. And the whole body, in the word whole body, there is also the word lung. And I showed images of lung ultrasound to my colleagues who were doctors, residents and students that were rather in this ICU at the first years. And I said to them, so this you can see there is a movement. So the lung is apparently at the chest wall. And little by little also I noticed these parasites, these comet tail artifacts that were the first name that I gave to the bee lights, because there were many other comet tails. So things came little by little. And I said to them, this patient has a pulmonary edema, likely. And little by little, I had to make the biggest work, that is, instead of speaking freely to my students, writing it in a regular way. Say it again.
That is the biggest work, is writing it up for the manuscripts.
Yes, the word is submitting.
Yes.
And submitting your research to a journal, it would deserve the whole book, My Life of Submissions. And I would insert, I will do that in many years when my reviewers will all be dead. I will insert the comments. That is, your paper has raised these questions, these issues, and some really should deserve to be gathered together. But I cannot do that now because I respect my reviewers. I repeat, I respect my reviewers anytime, regardless their decisions. The only thing is that I have spent all my life for publishing very few articles, very few. And the most important of my discoveries were either stolen, so to speak, or not yet published. And there is one that is that needs 5 steps to be in the marble. In the marble, you say, that is official.
Yes.
That is, I had first the idea when the B-lights showed that there could be present in a hemodynamic pulmonary edema and disappear once the patient was feeling better. I said, but maybe it is linked with a relation with the level of volemia of the patient. And I began a study that was successfully published after many rejections in the chest anyway. And but I used the surrogate for comparing these B-lights with something. And you can ask to all the doctors here, because they are world experts in hemodynamics also, not only in echocardio, but in hemodynamics. And the main problem of the critically ill, that is, where is this bottle? It's easy because it is transparent.
Sure.
Where is the level of fluid in this patient? And when should we stop before the fluid comes in the inappropriate places? And if I want to be more self-speaking, I would do that above my computer, my beloved computer. And the step 3, so the step 1 was discovering and publishing the B-line.
Okay.
And the clinical application is the Blue Protocol. The step 2 was to publish it in an article with the surrogate that was the Swan-Ganz catheter.
Okay, yes.
The next step was to make an original study. It was done. It showed data in a paper that was rejected maybe 12 times. I am not the corresponding author, but we do that in a good friendship, and the guy had to be rejected 11 times. Now it is in a scientific report with the surrogates, which is the esophageal Doppler. Never mind, we have numbers. These numbers, sensitivity, specificity, I make very basic statistics, are not perfect. And this is the interesting point. I'm sorry, my bracket is a bit long, but
okay.
we talk with a doctor, so they will understand, and it is completely technical. These numbers are not perfect, which means that my B-lights are not perfect, unless it is the opposite, because the gold standards do not exist. We use surrogates,
yes,
and maybe we just had the proof with the number that we have that the guilty is the transesophageal Doppler and the concept of a fluid responsiveness, which considers the increase of a cardiac index when you give fluids. I think that we push on an open door, because all the good doctors know that no parameter is perfect.
Yes.
And I just say with a smile, because I think that I keep the reality. I am not flying, I am on the ground, but I just say with a smile, modest, humble smile, that maybe the gold standard should be this B-line. I say maybe, why not? And please, is there somebody in the planet who can say to me, yes, this is the gold standard, or no, it is not? If you say it is not, you must show me a gold standard. And because there is none, I can say, but always with a smile, because I cannot prove the things. I just leave to the doctors a tool that considers a patient where you give fluids and where there is no B-line initially, and where suddenly at a specific moment, 1 or maybe 2 B-lines at a given field will appear, which is called the false profile, and which simply will indicate with the logic, because it is the only tool that gives a pathophysiological change, indicating that the subpleural interlobular septa that you have all over the lung surface is not 300 microns, but a little enlarged because of the fluid excess that comes initially in this segment, which is completely asymptomatic. And it should be time to switch off the fluid therapy and consider that the patient received adequate volume of fluid. That is, I would say, at this level. Not here, but here. So I close the long bracket on the Folds protocol, and the story begins with the whole body ultrasound that I succeeded to publish in the 1991 in intensive care medicine, and then I spent all my life with the lung, and the lung. I did one work on the maxillary sinus opacification.
Yes. I learned about this from a colleague in Minneapolis who says he has a ton. This is primary care, not interesting for you, but
primary care, yes, of course.
But if it's fully opacified, if you can see the back wall, there's the fluid there. I'm curious, how do you incorporate the maxillary sinus?
By accident.
Oh, okay.
I think I was making a study that has never been published apart from an abstract. But
explains what happened here.
But maybe the date of the abstract shows that it was the first one on the optic nerve.
Okay.
And my probe fell a little bit, and I saw a big image showing the shape of a sinus that I called, by the way, sinusogram.
Okay. Okay.
And I studied the phenomenon, and I made a study on that. I don't regret to have made this study. I just regret the time that it took, and the energy that I spent since 34 years compared with the very few number of articles that I succeeded to publish. I speak of the original articles, unsolicited. And maybe there is a rate, all the time spent with things that were failures, above time spent for things which were published. And maybe it's not the Hirsch index that is the Hirsch index.
Yeah, I don't care about that.
When you publish something, is the paper read or not? Mm-hmm. It should be the L index, maybe, that is the Lichtenstein index. Okay. And maybe I have a efficiency of, I would say, 15%. That is countless hours up to now spent for nothing. Lung ultrasound in the baby, for instance. And I just stop here because there are many things. When doctors insert a venous line using ultrasound, they do not know that it was in my 1991 article. They don't know, but I say it, and now they know.
It's the standard of care, yeah.
It's the standard of care. Yeah. And I did that in the night in all my patients that I received in the night, and in the subclavian vein. And not the subclavian, which is above the clavicle, but below the clavicle. Yeah. That is in a clean area. That is, ethically speaking, the best choice, so to speak. But life did not give me the opportunity to make an original paper about this, and it's the cake.
The cake.
And me is the cherry.
Yes. So another thing that I very much appreciate, you wrote a piece about misconceptions in lung ultrasound. I know you do whole body ultrasound, but I was curious for people who are watching, what do you think, if you had what's your biggest pet peeve or the biggest thing you think people get wrong? The biggest misconception.
Wow, I like it. It was nothing is expected. I love this very
improvised. Yes, this is impromptu.
Yes. So congratulations for this choice, because this question I can answer during hours and days. And what was the genesis of this paper? I was in connection with CHEST. I wanted to write to them some update on the Blue Protocol, and they said, would you be comfortable by writing a paper of your choice, but a commentary. A commentary is not an original article. It is peer-reviewed, but there are no data, no numbers, no statistics. And I said, yes, let's do it. And it's a 2,500 word article, which contains 43 misconceptions. It's a lot, but
nice.
It was...
graphics, pictures, it's,
I should remember all my babies, but maybe there is one image about the bilites and the lung rockets, to be sure that things are well understood. So I would say maybe not the most wrong misconception, but the most symbolic for me is so people who know me will smile or will say, he will not speak of that. No, the subpleural consolidations.
I had that guess. That was my guess. I should have said it first, but I didn't want to lead the witness. Okay.
Because it is a very simple and logical way to show that we can improve the nomenclature, the terminology. We, that is the planet.
All of us.
And I understand what they speak about. We all know what is a lung consolidation. It looks like solid, but it is fluid, by the way. But let's, it's not the point. When it is subpleural, that is, this is the parietal pleura,
yes,
and this is the consolidation coming inside the lung. This is also the visceral pleura here. If the consolidation touches the wall, it appears in your screen. And you can diagnose this consolidation, and it occurs in the critically ill in more than 98% of cases. So it's a good opportunity, it's a providence. And the consolidation is subpleural, and you can see it. But the doctors who created the word were considering small consolidations. That is, you have the pleural line and a consolidation making, let us say, 1 centimeter. And after, you have the aerated lung. And I kindly, with high respect, say to these people that when you have a complete lung consolidation affecting the whole of the lung, it is also subpleural.
I agree. It is below the pleura.
I'm a bit sorry. And I was a lot surprised to see that instead of receiving words of thank you, I received obstacles. And people said, no, you have not understood. These consolidations appear after a surgery, or they appear when the patient has a pulmonary embolism. It's not the point. And I said, quietly, yes, okay, but you tell me about the etiology of consolidations, but they are subpleural. You can withdraw the word subpleural. If you write a manuscript of 2,500 words, there is an empty space of maybe 70%. Patients and method, we recruited 100 gentlemen, 200 ladies, under mechanical, blah, blah, blah. So you have a very few number of words for expressing your originality. If you say subpleural consolidations 20 times, you lose 20 words. It's a lot, it's a whole sentence. And I say this word is useless, please. And if you want me to understand you, just say small.
Small
consolidation. Okay, yes. And you can even say small subpleural consolidation. I will understand what you mean.